Okay. Yeah. So, I'd say please feel free to put on the camera if you want to. Otherwise, I try to keep this informal. Yeah. If you have questions, just ask in between. We also have the chance to ask questions at the end. But I think the whole idea is to that you learn something out of that. And if you all know this stuff already, and then we can just move faster and do more interesting things. Or if you want more details, then just ask questions. Yeah, like I mentioned, recording will be online. I will also send some. Unfortunately, I was a bit busy this week, so I couldn't manage everything I wanted to do for today. But there will be another email with some feedback and some information like from the first meeting we had. And also like this doodle link to find some dates for the 1 week course. Will all be sent until the weekend. And unfortunately, I was I was fortunate enough to travel to Brussels and see the European funding landscape, which was pretty interesting. So, but now back here and talking about pharmacokinetics. Yeah. Today the main topic will be pharmacokinetics. Because I think this is really at the heart of our project. Yeah. Just a quick reminder. The main idea is really to build physiological based pharmacokinetic models of this ACE inhibitors, lisinopril and ramipril. And a large part, and I would say the most important part, is really the pharmacokinetic parts. We have to understand if we take these drugs, or if a person takes these drugs, how is it distributed, eliminated, absorbed, and so on by the person, that we get this time concentration curves and can simulate that. This data is pharmacokinetic data is especially important for the models because we need it for to build the model, basically to fit parameters and to also to evaluate model predictions, which we do with the model. So without the data, we can't really build a computational model. And at the heart of this model will be a pharmacokinetics model and pharmacokinetics data. And if there is good data and if we're fast enough, we can also capture like the pharmacodynamic part of the whole thing. Yeah, so far so good. So pharmacokinetics. Let's say as a quick motivation, why is pharmacokinetics and understanding of pharmacokinetics important is basically because we want that the medication that people take does what it should do. And this normally expressed as this term therapeutic window. And it means that there exists plasma concentration. You can see my mouse, yes or no? Otherwise, I'm doing.
Yeah.
Yeah,
Mouse
perfect.
can be seen.
Perfect. So, yeah. So, therapeutic window means basically that there is a certain plasma concentration where we have like the desired effect of the drug. If we don't get in this area, normally our concentrations of the drugs are too low, and we don't see really an effect of the drug, and we see ineffective therapy. On the other hand, if we go too high with the plasma concentrations, then more and more adverse effects occur. And of course, we want somewhere to be in this sweet spot. And understanding of the pharmacokinetics of a drug helps us to adjust the dosing and the dosing frequency and so on to hopefully get the people in this window where things happen that should happen. In our case, this would be okay. We have to give the right amount of ramipril or lisinopril, so that we have the desired reduction in blood pressure. And we want to be somewhere here in between. Yeah, there are a ton of definitions of pharmacokinetics. I think one I liked was that it is a quantitative study of drug movement in, through, and out of the body. I would say this describes it very well. It's basically if we give certain substances, be interested in how they really move, distribute, and leave the body again. I gave last time the example of caffeine. I think this is a pretty nice example because we basically see this very typical curves after oral application of a substance, that we see this rise, and then afterwards, due to elimination, like this going down again in the substances. Yeah, importantly, the intensity of the effect is really related to the concentration of the drug. This is what we saw in the first slide. Okay, we have this pharmacodynamic part and the pharmacokinetic part. And the pharmacodynamics is basically depending on the drug dose, we have certain effects. So it, yeah, of course, the pharmacokinetic parameters will affect the concentration, and the concentration will affect the pharmacodynamic effects. Yeah, understanding the pharmacokinetics is important because we have to understand it to determine how to administer drugs. Should we give it orally, intravenously, or via the mouth, or via skin, by the skin? And yeah, depending on the pharmacokinetics, certain things can work better and we get better effects. Also dose and frequency of dosing, like I showed in the last slide, and also other important thing like onset of action. Of course, if it takes very long for a substance to be absorbed and to actually take effect, then yeah, this is important for the dosing. Also, when is the peak of action, and how long will be the action of the actual drug be? Like mentioned last time, there are four key processes which play a role. These are the so-called ADME processes, which stand for absorption. So how will get the medication in the body, the distribution, how will it distribute and where will it go, how it is transported, how can it reach the site of action. We have metabolism, how is it broken down and converted to metabolites, or is it broken down or not? And also the excretion, how is the whole thing going out of the body again. And in the end, we have like this time courses of plasma metabolites or concentrations in different tissues. And we are interested in understanding why these curves look like that, and yeah, what things could affect these curves. Yeah, what normally happens when we have these curves is that people calculate pharmacokinetic parameters on these curves. There are some which are very simple to understand. I would say the maximum concentration, Cmax, or the time of the maximum concentration are pretty intuitive. If we have such a curve which is going up and down, okay, it's pretty clear what this means. Other things are also like, if you know that AOC stands for area under the curve, then it's somehow also clear, okay, this is just the area which is here under the concentration time curve. And it's also, I would say, pretty clear how to calculate that. But there are also a bit more complicated pharmacokinetic parameters, which we have to calculate a bit more. The calculation is a bit more involved. The first one is the elimination rate. Elimination rate means basically how fast is the concentration or the drug removed from the plasma, and you can calculate this from this decreasing flank in these curves. What is normally done is that you do a logarithm of this plasma concentration time curves, and then you look for linear phase and interpolate this linear phase to get a rate of decrease. And this rate of decrease is basically the elimination rate, this parameter. The elimination rate is yeah, very tightly connected to the half-life. It's basically just calculated at ln2 over the elimination rate. And yeah, often I find the half-life a bit more intuitive. Yeah, well, so what is half-life? Half-life means basically the time for it takes for the concentration to halve. Yeah, here in the logarithmic plot, it's basically, okay, how long does it take until it goes from 20 to 10? And how long does it take from 10 to 5? And normally every half-life you have the concentration is only the half. So also very intuitive. Other things like volume of distribution, a bit more complicated. It's like a virtual volume in which the substance could distribute. I would say a bit more about that later on. And then there's also clearance, which is basically calculated at something. How much do you give, and how large is the dose of the substance you give? And you divide it via the area under the curve, and then you get an estimate, okay, of how fast is this removed. You can imagine the larger the dose and the smaller the area under the curve, the faster this is cleared from the system. So this is somehow a good parameter to estimate, okay, how fast is this can this cleared from the body. I would say these are the main parameters you will encounter. There are a lot of other things which people could define and have defined on these curves, but these are yeah, I would say it makes more sense to read up on that, and instead of like now presenting the most obscure pharmacokinetic parameter you can find. Yeah, but I would say this is basically what pharmacokinetics is. Look at this time curves, calculate parameters on that, and then use this data to do things. Either like many of these clinical trials which look at pharmacokinetic, they basically just take two groups or two interventions and then look at the differences in the pharmacokinetic parameters. But of course, in our use cases, we want to use this data for building computational models. So I will give a bit of example on like I'll say like on a substance which doesn't really exist, but it's a nice example which illustrates some of what you will encounter when working with the pharmacokinetic data and looking at pharmacokinetic data. So this substance is called pretenderlone, and we pretend to make a trial with this substance and give two doses or two different applications of the substance. Once we do an oral application of 50 milligrams, or we give an intravenous bolus injection of 2 milligrams, and we do this to 5 subjects. And this is, I would say, a very typical design of such a trial. You have like a low number of subjects, like normally 5 to 10. You have two interventions. Often this is different doses of a substance, or you have two different subgroups and so on. So most of the time it's like you have two things which are different between the two groups, and then you compare what is coming out in the pharmacokinetic parameters. So how does the data look which comes out of such a clinical trial? In this case, I first show the oral application. And what you normally have, you have then in the end a table in which you have time data, like basically the concentrations are measured at different times. And if you're lucky, for every subject, the data is reported, and you get concentration time curve. For instance, here for subject 1, after 1 minute, you had a plasma concentration of 0.51. The units are not given here. I are here in nanograms per milliliter plasma. So these are basically the plasma concentrations you observe in these 5 subjects, and then of course you can calculate things on these 5 subjects. Basically, you could make arithmetic means, geometric means, calculate standard deviation, coefficient of variance, and so on. Yeah. So, like I said, if anything is unclear or this is all clear, please just ask. Exactly. This is how such data looks, and then you can go and plot such data. This is now these plots which correspond to such a trial. And what you can see here is basically you get this rising flank, and then it goes down again. What one can say, yeah, it's already looking a bit more noisy than this very nice example curves you always see. And often it's due to the sampling. Of course, you only have samples at certain time points, and this makes it a bit noisy. And of course, you have also like inter-individual variability. This is an example where the inter-individual variability is very, very low. So basically, this looks all very basically identical and very nice. And so this is, I would say, the ideal data, pharmacokinetic data you can find for a substance. You have individual subjects. They are all very similar and nicely reported. And you have, if you're lucky, even a table which is providing the actual data values. What you in reality most of the time will see is more something like this here. Often the data is like semi-logarithmic, and they don't report the individual subjects, but they just build means of the groups and report some error measures, often this SEs, because they are very small or smaller than SDs, or in this case SDs, but they're also they're pretty small here because they were pretty similar, the data points. Please note, the logarithmic axis, this is really critical. You see this also a bit reflected in the error bars. They are like larger going down here because it's just, it means something different to go up 1 centimeter or whatever here in this plot and going down 1 centimeter in this plot. Yeah, and normally this is also what is then reported in paper. In a paper, you get a short description. Okay, what is plotted here, and for what intervention, and what are the error bars. This is and some units of what is reported. So this is a nice example of pharmacokinetic data. The big question is, where is this upcoming flank after oral application coming from, and this downgoing flank? So it's very simple. It takes some time until the drug is has done the passage through the stomach, and the tablet is dissolving, and absorption can take place in mostly in the intestine. And this results in some delay until the drug is really appearing, and over time the drug is appearing. As soon as drug is in the systemic circulation, of course, if there are elimination processes, then they start, and drug is eliminated. But can you imagine, like if the absorption is still dominating, then you compared to the elimination, then the curve is still going up. And if this is exactly equal, the absorption equals the elimination, then you're exactly at the maximum. And then if the elimination becomes stronger than the absorption later on, then you go down in the concentrations again. So it's normally what happens here, that you have like this different phases. First, drug absorption in the gastrointestinal tract, and then you have the drug elimination from the plasma. I would say, and this is pretty similar for all substances. The main thing which is different is the time frames. How fast is that? And also the time frames here in elimination rates, and sometimes also the how linear or non-linear these curves are in the end. Here what you then can do for our example, we had now this 5 concentration time courses, and we can calculate these parameters, like here, like these simple parameters. We can calculate for every subject. Okay, where's the maximal concentration? And we see they are pretty close, and somewhere here between 86 and 92 or 98, sorry, and 98 nanograms per milliliter. And our maximal concentrations are around 1 to 2 hours. Here we see also a problem, like in these times. Of course, this is often not the real maximum of the curves, because we have to adjust a certain sampling, and if we haven't sampled close enough to the maximum, then these are just approximate values for the maximal concentration, for the maximal concentration time. Yeah, and then you can do mean, standard deviation, coefficients of variance on these parameters, and so on. To calculate the elimination rate, what you normally do is, like I said, you make a logarithmic plot and then interpolate.
May I ask you?
Yeah, please ask.
There are 5 subjects, and they're divided into just 5 groups of people with different, I don't know, age, appearance, race, or something, or just random?
No, they are just five subjects, but of course they could be different in certain parameters. Normally, I have to admit, normally what people are trying that they get their study groups as homogeneous as possible. So they would often, these are just 5 medical students between 21 and 27 years, and all male most of the time. Like nowadays not so much anymore, but 80s, 90s, and so on. It was mainly 5 young male medical students. Yeah, but of course they. You could have different groups of different subjects and then compare between these different subjects. This we often see, but then you would have like a larger sample size. You would, for instance, have a study not of 5 subjects, but of 10 subjects, of, for instance, 2 groups which have different ethnicity or so on. And then you would just see 2 times 5 curves, and these would either be different or not different, and you could then use things like, okay, they have these 2 groups, like I don't know, the Caucasian and the Japanese people I looked at, they have different Cmax or Tmax values, and this could be informative and help you like in understanding what's going on with the drug.
So maybe I didn't get it right. Subjects are group of people, not.
No, subject is really an individual person, and normally for the groups you say either group or cohort often, or subjects. But one subject is basically an individual person.
Okay, then I didn't get it right.
Yeah, sorry, but yeah, exactly. Like asked like that, for me, it's often for me I have to work with this terminology all the time. Yeah, if just ask about that. No, here it's really 5 people. Okay, five persons, and for we measured an individual curve.
I have one more question. So, is it always so? Like this tendance is for each drug that we get and try to test?
It depends. Yeah, let's say I would say most of the time we have things which are looking very similar like that, and it's most of, like, if you look at the plasma concentration, and it's most of the time because if you give something, it somehow appears first, and then it disappears. But of course, the way of disappearance and where it goes can be very, very different for different drugs. Like it could be vanishing because it's just metabolized, for instance, in the liver to a different drug. It could vanish because it's excreted via the urine or the feces. It could also vanish because it's just very hydrophobe, and it's just going in the fat tissue and staying in the fat tissue forever. Example for that, like really the cannabinoids or something, which are just staying for weeks in the fat tissue and so on, and they are just vanishing from the system, but they are still, like, let's say they are still in your body, but you can't measure them in the plasma. Other things are like heavy ions and stuff like that. It's basically not leaving you, or this microplastics or whatever. There's lots of stuff which is basically it's vanishing from the plasma concentration, but it's somewhere else. It's an adduct to a protein. It binds to the membrane and so on. So it could just basically the free concentration in the plasma is most of the time going down. Mainly because we have a lot of turnover, like a lot of clearance in the kidneys and so on. And normally we have a lot of transporters, so the stuff is transported somewhere or eliminated from the body. I would say overall this is like that, but there's also there are many exceptions to this very general rule. But I would say okay, if you have to make a guess how your curves would look, I would guess something like that. Okay.
Okay, thank you.
Okay. Yeah, exactly. So here we can now calculate for this five subjects the parameters, and then compare them. Yeah, the elimination rates, like I mentioned, it's basically an interpolation of the concentration versus time. And you try to get here a linear rate out of that. And normally this is an assumption of first order elimination. This would be just let's say an exponential decay in the normal concentration range. In the logarithmic range, this will be a straight line, and you can then estimate the slope of this straight line. Like for instance, what you could do, that you just take the concentration at one time point, like at 4 hours. Those are probably this data points here, and the concentration at 36 hours. That's the last time point here, and then you can calculate the elimination rate, via simple formulas. Okay, I don't put too much formulas on here. I would say like most of, you can look this up, and it's not too important for the actual work. It's more important to understand, okay, what do these parameters stand for, or what are they representative for? And elimination rate means more like, okay, the higher it is, the faster we're going down, and it's inverse related to the half-life. Of course, I hope I say the right stuff, but the faster going, so the faster the elimination rate, the shorter the half-life. Also, like the larger the elimination rate, the smaller the half-life. So it's basically inverse related. This makes somehow sense. Or if you think about it, it makes sense. Yeah. There are many things which can affect these curves. One example I wanted to give is really like different formulation of drugs. These often play an important role. And in this first example, we have, like, for instance, a tablet, which is a fast release tablet. And it means basically if you take this tablet, it's dissolving very fast, and the drug which is in the tablet is getting in the system very fast and can be absorbed very fast. And that means that a lot of the drug is appearing in very fast. So in the first 2 hours, most of the drug stored in the tablet is released and can reach the plasma, and then elimination can take place. And that means like there's often like this flank is very, very steep, and you get to the maximum very fast. And in the end, you almost have no release because everything is already in the system after 2 hours. Like like these tablets are one example, but of course it depends also on the formulation. Like for instance, if you take solutions or fluids, then it's much faster absorbed than if you take a tablet or and so on. Like for instance, alcohol and so on, it's very fast because it's most of the time in as fluid, and it can reach the system like in 20 minutes, 30 minutes. This is normally the time it takes for the stomach passage if you are in the fasted state. Yeah, there are many things which can influence how fast the absorption is. Examples are, for instance, how much you ate and so on. Or did you eat? Are you fasted? And so on. So there are many factors which can influence how fast this is going up. Drug formulation is one example. If you contrast to this fast release, there are also like slow release tablets. And these are just releasing not so much in the initial phase, and it just takes longer for the drug to be freed from these tablets, and more is going out of these tablets in later time points. And of course, you get a smaller, it takes longer to reach the maximum, but also like the elimination rate is somewhat affected by that, because basically only what is appeared in the plasma can be eliminated. So if you calculate the elimination rate based on the plasma concentrations, so this very slow absorption over a long time will also affect the elimination rate. The second example is the intravenous application. This is basically the same study design. We have five subjects, and now we give them, instead of this 50 milligrams as a tablet, we can give them a bolus injection. This is often for substances which are not. Many substances are destroyed in the passage through the stomach because we have very low pH, and many substances are pH labile, and they are just getting destroyed, and not much is appearing in the intestine. Or certain substances, for them it's also very difficult to cross the intestinal barrier and get actually absorbed. A good example is, for instance, insulin, and people would probably love to take an insulin tablet, but they still have to take the injections. But depending on the injection sites, also you have different absorption or appearance kinetics. That's why you have like you can either inject directly in the the veins, and it appears very fast. But often you have like this subcutaneous muscular injections, and then it just takes much longer from the muscle tissue to appear in the systemic circulation. So this is, I would say, for the whole pharma industry and the drug design and so on, this is really important. Okay, how fast and how effective are we getting the drugs in the system? For the intravenous application, the curves looks a bit different, and it's more like because as soon as you have it injected in the bloodstream, this is like distributed very fast, and basically you put the whole amounts, like the 2 milligrams in this example, within a few seconds in the bloodstream. And so, like if you measure here, like after a minute, basically the complete amount is already in the system. But you will see also like a bit of strange phase in front here. You see it here on the logarithmic plot, this linear decay, which is like the elimination rate. But you also see this initial phase, which is mainly a distribution phase of the drug, because it takes some time to circulate, and the drug can go in different tissues, and depending on where the drug could go, or if you could bind plasma proteins and so on, you will have different initial distribution phases after intravenous application. But overall, I would say the initial phase looks very different. But as soon as you go over this distribution or absorption peaks, like the elimination often looks very similar, because it's basically then just drug in the plasma, and it doesn't depend on how it reached the plasma. The same elimination processes take place. You have this 3 phases. Let's say the beginning is basically drug at the first time point. Then you have this distribution phase, and then later on the elimination phases of drugs. And similar to the oral absorption, you can then calculate via the concentration over time. You can calculate this elimination rates given here. Here a bit of example of half-lives and elimination rates. This strongly depends on the drugs, and you have this reciprocal relationship. And if you have like some rates of around 0.1 hours, that means that you have a half-life of around 7 hours. So if you see K is somewhere 0.1, then it will take 7 hours for the halving, and similar here. I think this it's a pretty nice table, and it helps a lot if you have like a bit of feeling between what means elimination rate and half-life, because this helps you a lot like to interpret also the pharmacokinetic data. And we see like for different substances, we have very different half-lives. This can range from certain cancer drugs or acetaminophen, which is very, very fast, and in a few hours everything is removed. And this is also of course reflected in the dosing protocols and so on. So like for paracetamol, people always say, oh, every 8 hours you should take 2 tablets or something like that, but this is it makes somehow sense, like because after if you half the concentration every 2 hours, around every 2 hours, then okay, after 8 hours you have almost nothing in the system. And this goes up until half-lives of 2 to 5 days. So like if you consume like cannabis or so, like basically you're still having the half dose after 2 to 5 days, which is like I don't know. I found this very interesting. But stuff like that is really to take into consideration. Okay. Area under the curve. I would say this is pretty intuitive. We just have to calculate, okay, what is the area under the curve of this concentration time course. What you often find in the studies is something which is mentioned. It's the trapezoid rule to calculate that. And that means basically, okay, that you, I don't know even what structure this is, but you build you build this trapezoid and calculate the area of this trapezoid from these data points. And if you sum then all this trapezoid up, for all these two neighboring data points, then you get the complete area under the curve, under this curve. Let's say also pretty straightforward. Perhaps also take into consideration there are of course very different curve shapes which can have the same area under the curve. You could have like very fast absorption, fast elimination, and get this area here, and this is basically equal to something which has slower absorption and slower elimination, and in the end the area is approximately the same. So often these pharmacokinetic parameters make a bit of sense in the combination. If you know, okay, what is the elimination rate and the area under the curves and so on, then it's more clear what the shape of the curves is. Yeah, but many of the things I'm showing here are really idealized. Like often this is not going down in a straight line, but it's like, and you have much more noise than in this data here. So the data I'm showing here is, or this pretended data is basically the ideal case of pharmacokinetic data you could find. What is happening often in the area under the curves is it's an extrapolation. This is called area under the curve interpolated to infinity. And what is done here is basically that you calculate your area under the curve until the last data point. But then if you have this straight line, you can of course extrapolate it, basically using the elimination rate until it crosses somehow the y-axis, and then you can extrapolate, okay, if I would have measured like a day more or 2 days more, where would it cross and what would be the remaining area which I haven't measured. And this is a nice extrapolation because it allows to compare different studies with different endpoints with each other. You can imagine if you stop too early to take data points in this clinical trials, of course, this interpolation will be very bad, and also this extrapolation will have a large error. Okay. Yeah, almost last but not least. Yeah, sorry, it's a bit technical, but I think today you really have to hear all these words once and get a bit of feeling, okay, what they mean, because we will see them a lot, like when we work now with the ACE inhibitors. So volume of distribution, like I mentioned before, it's a virtual volume, and it's calculated based on the dose and concentration. Yeah, okay, very, very easily. You can imagine you have a dose which you give, like in this case, a dose of 100 milligram of the substance. Then you can measure an actual concentration in the plasma, for instance, here 1 milligram per milliliter, and then you can calculate this volume of the vessel. Let's say like this, by just dividing I have to do it the right way, by dividing the substance through the concentration, and then you get a volume. In this case, it's around 100 milliliter. Exactly. What can now happen, and often happens in reality, that your substance is bound to certain things or absorbed. And bound means often there are a lot of plasma proteins, like albumin is one of the key players in this protein binding, and the drugs or many drugs can bind to this protein. And by that, the free concentration which you measure in the plasma is much lower than the actual plasma, because a lot of it is just associated to proteins or associated to tissues and so on. And so the actual concentration you measure is much lower, like in the plasma 0.1 milligram, and then you get a much larger volume of distribution. And like I said, this is the actual volume of our body didn't change and of the blood compartments, but it seems like this virtual volume became bigger because the drug went somewhere else, and it basically went binding to proteins, or it distributed in tissues, or it's just stuck somewhere. For instance, like stuck in the fat tissue or so on. And so this is an interesting thing. But you always should have in mind this is a virtual distribution. Like here also we have the a few examples, and this can range like from okay, this is mainly located in the plasma volume space we have to, okay, these values are getting much higher. Normally, yeah, we have around 10 liters of plasma. And this goes much higher, and it's often because this is going into the fat tissue. Like for instance, for the cannabidiol, they are just stored in the fat tissue, and this is also related to the long half-lives because it just takes long until they're coming out of the fat tissues again. Yeah, I would say, long story short, this is basically what you typically will see in summary. It's mainly like you see concentration time curves. This can be after different application, for instance, on the left after oral application, on the right after intravenous, because this could also muscular and so on. And then you calculate pharmacokinetic parameters on these curves. Yeah, I think I mentioned most of these here. The oral bioavailability I didn't mention. This is basically what you can parameter which you can calculate after, okay, you give a certain dose like orally and intravenously, and then you can calculate how much of the drug really appeared after oral application. Yeah, but also not too important right now. I think the main takeaways are really like elimination rates, half-lives, the AOCs, AOC interpolated, this volume of distributions, and also the clearance. And clearance is just calculated from these other parameters. It's basically calculated from dose and elimination rate and volume of distribution and so on. Okay, I think this is the main thing you have to understand. If you got the gist of that, then you good to go. If not, if you have questions, then I think this yeah, you just ask them, and but there are also like a lot of nice introductions to that. I also have 2 books I can recommend. They're not too expensive and pretty basic. Yeah, but they I would say they do the job to understand what these parameters are. Yeah, are there questions until here? Or points for discussion and so on? Okay, if not, then yeah, just jump in if you have questions. Otherwise, I would talk a bit about variability, because this is a big, I would say, a big thing, and also a big thing in building pharmacokinetic models to explain the data. So yeah, our main goal is to have computational models which can simulate this here and understand why, if we have now different groups, why these pharmacokinetic parameters could be different, or why the pharmacokinetic curves could be different. So variability is yeah, can be different variability. Often it's like intersubject variability, but in case like on this high level view, we have also a very large variability between drugs. And this is just here to show 2 examples. That we now looked a bit at this pretenderlone example. But of course, if we now look at 2 different drugs, things can be look very different. Like for instance, here on the top, we see 2 drugs which have basically different half-lives, and as a consequence, also different AOCs. Yeah, and on the lower part, we see 2 drugs which have basically the same half-life, but different initial and total exposure time. So they have different AOCs. So it's like this is 2 examples how different these curves can already look. We see always on the left side now the non-logarithmic values, on the right side the logarithmic values, and we see, okay, here the same elimination rate, and on the other hand the same half-lives. And basically this is there's a large difference between the drugs. Like here, just 2 examples. Like here is, for instance, the volume of distribution and the clearance, like two pharmacokinetic parameters, and we can see here this are also logarithmic axis. So this is really factor 100, factor 1000 differences between the different drugs. And then we have some with very large volume of distributions and large clearance, and basically all over the, I would say, like drugs are like all over the place. And understanding then for the individual substance what is going on, yeah, the pharmacokinetic modeling and the physiological based pharmacokinetic modeling can help a lot in understanding why the substances are have that kind of pharmacokinetic parameter. But of course, we have to understand what is happening with the substance and why it is like that. And this is a lot of which the work which we have to do to understand to build this model. We basically have to understand, okay, what is the pharmacokinetics? Why is it like that? And how can we include that in the computational model? If we go to the inter-individual variability, like the first one was basically the drug variability. Now, if we look at a single drug, we still see a very large variability. And like here, two examples. Like on the left, it's basically the concentration of a drug, phenytoin, and depending on the daily dose. And normally you would expect, okay, if you increase the dose, you could just get a linear or some relationship between the actual dose you take and the plasma concentration you have. If you remember this initial thing, like this initial plot with us, we want to be in the therapeutic window, and if the therapeutic window is in a certain range, and then we recommend you should take, I don't know, 5 milligrams per kilogram daily. And we lie all over the place, then it's of course very difficult to get in this therapeutic range. And this is, I would say, this is for most of the drugs like that. It's more like, okay, for many people things are working, but for also many people this is just ineffective, or there is a risk of side effects, and it's often very it's difficult to say why, but computational modeling can help to better understand where this variability is coming from, and of course then also help in adjusting dosing and so on. On the right, there's a second example. Here it's about the variability in plasma warfarin, and we also say that we have basically we have a large distribution of the concentrations, and most of the people lie in a certain range, but there are certain people which have very high concentrations, and there's risk of adverse effects, and other down here probably they should take more of the drug, and it's not really working for them out what they're doing right now. A big problem in variability is basically related to non-adherence. What this means is basically adherence. How regular and consistently are you taking your medication? And it's basically most of the people they get the medication, and it's or it's said you should take your I don't know, your blood pressure medication for the rest of your life, and every day one tablet. And this is like, and this is basically what is said. But the problem on this is a prescribed dosing regime. But then the patients basically I don't know, over time, less and less of the people are doing what they are told, or they just forget it and don't get another prescription and so on. And this, of course, affects how much drug is in the system, and often you have like the wrong effects. Or like people are like, oh God, I forgot to take my drug yesterday, so I take 2 tablets today. So, this can, depending on the pharmacokinetic parameters of the drug, this can be a big problem, because of course you're getting double peaks, and basically double the height in the peaks often, and you can just jump out in this upper region where you don't want to be. And is this really a problem? Here's a very nice example really for the antihypertensive drugs. This is basically what we're trying to do. And if you look at the percentage of patients who adhere to the drug, you can basically see that after 1 year, only around 50% taking actually the prescribed drugs that they should take. And these are all people who should take this for 10 years, 15 years. So the question is, okay, this is really problematic, and around half of the people after 1 year don't take the medication they should take. Most of them really stop and discontinue. It's often like if the tablet box is empty, they just don't get another prescription, and that's it. And then it's, I don't know, in 5 years, if they go to the doctor again, they ask what happened to your hypertension medicine, and then they say, oh man, I should still take that forever. Okay, so they restart again. But this is okay. This of course results in a large variability, and also in it's a big problem for the healthcare system. Other big influence of variability is really the variability in drug metabolizing enzymes, but also other enzymes who are involved in the pharmacokinetics, often transporters who transport the drugs into the tissues or eliminate the drug from the system, for instance, during the filtration in the kidneys, or enzymes such as cytochrome P450s in the liver, which are responsible for the metabolization of many of the drugs. There are many isoforms of this cytochrome P450, and they are all specific for different substances. Caffeine is done via the CYP1A2. Ethanol can be metabolized via CYP2E1, and so on. And first, there's this zoo of different isoforms, but in addition, you have also a large variability in the concentrations of these isoforms. This is mainly, you see this here. If you just look at the enzyme abundance of the different isoforms for different subjects, then you see a very large variability. What is done here basically is a liver histology, and then they take a sample of the liver and look for individual subjects. What is the amount of proteins you have? And we see this is a factor 10, factor 20, and so on, which can be different. And depending on that, if you have, like, for instance, a very high CYP1A2 concentration, then of course you will be much more rapid in the metabolization of caffeine than somebody who is has a very low enzyme abundance. And this, of course, has a strong effect also on the pharmacokinetics, because depending on this, the amount of the enzymes who eliminate and metabolize drugs, you also get, of course, different elimination curves in the pharmacokinetics. Another thing which can affect the variability, and for certain of the enzymes has a really strong effect, is the so-called pharmacogenomics. This means more basically that for your enzymes who are involved in drug metabolism, drug elimination, or transporters, or enzymes catalyzing key reactions, you have different variants. So it's often called genetic polymorphism. So you have different variants, and your different variants have different activities, and depending on what combination of alleles and variants of your drug metabolizing enzymes you have, you can be either like a slow metabolizer who is has slow elimination rate, or it can be a fast metabolizer who has extensive metabolism. And this here's one example. Depending on the number, for instance, of functional CYP2D6 genes, this is we have a large difference in the pharmacokinetic curves. Like to the question before, like here we basically see a comparison between 2 different or 3 different groups. We basically have even 2, 4, 5 different groups, and we just see, okay, how the different groups are different from each other, and the groups are depending on what type of genes you have, or what variant of gene you have. Yeah. Overall, like I said, there's a large variability, and to understand that is really crucial. A key component to the actual building of the model is that we store and handle the pharmacokinetic data in a standardized manner. I'll say the main building blocks to build such a physiological-based pharmacokinetic model for a substance are shown here. Big things is you need software and like the right tools to do that, also compute infrastructure. But these are basically things which are solved, and you won't really touch in this project. I think the main thing you will touch is like really that we need models which are reproducible and reusable, and on the other hand, you need the standardized pharmacokinetic data, or later on also pharmacodynamic data. And if you have all these building blocks together, you can then apply such models and do actual applications. To store the data, we basically developed a pharmacokinetic database, and often a big part of building these models is really extracting the pharmacokinetic data and pharmacodynamic data from publications, and then storing them in a standardized way. And from there, we can then use it via programmatic access and scripts, use them to build computational models or perform meta-analysis and so on. I will quickly show how this looks. It's basically an online database, and there are already a lot of studies in there. unfortunately, nothing for ramipril and the other ACE inhibitors, as far as I can tell. Yeah, but this will be extended, of course, in this project. And yeah, what you normally do in such projects is that the publications which contain pharmacokinetic parameters are read, and then the important information is extracted. Like, for instance, here is a small example. Of course, we're mainly interested in the actual time course data. For instance, here's an example for caffeine for males and females, and females taking oral contraceptives. But there are also this pharmacokinetic parameters. There are also this pharmacokinetic parameters here. These are the two things, but what we also need in addition is the actual interventions. This is related to the dosing. So what was given in what amount, and what were the formulations in which they were given. It makes a big difference, as I mentioned before, if you give a capsule or a tablet, slow release, fast release tablet, or give a solution. So this is really key information for the computational modeling, because you have to understand, okay, what was done that this data was produced, and in which group was it produced. And this group is badly done in the yellow part here. We also have to figure out what were the characteristics of the subgroups, like what was the age, weight, ethnicity, did they smoke, did they use oral contraceptives, and so on, because many of these factors can have an influence on the pharmacokinetics. So this metadata categorizing, okay, what were the groups, for instance here, were they normal males, were they females taking oral contraceptives, and so on. This is important to understand the parameters and also the differences in the parameters. Yeah. Yeah, this is not the nicest database, but I think the important thing is that in the end you have different groups for which different interventions were applied. In this case, caffeine was given as 250 milligrams, and then you can measure here in this case the time courses from the publication. And this is basically the data which is directly going into the computational models and building computational models. Like, for instance, here, a computational model then to study, okay, what is the effect of oral contraceptives on the clearance of caffeine? Yeah. So this database will be one thing you definitely have interaction with. And it's basically to curate and prepare the data which you will use to build a model. Yeah. We did this for certain substances, for caffeine and so on, and then you can curate a lot of data and bring it together and look more systematically at effects certain lifestyle choices or certain co-medication will have on your pharmacokinetics. Here, for instance, we looked at caffeine clearance and the effect of oral contraceptives. These are these orange groups down here and here on certain pharmacokinetic parameters. In blue, we also were interested in smoking and oral contraceptives. We can basically see compared to black, the controls. Smoking has basically results in an increase in clearance and then decrease in half-life. And if you take oral contraceptives, then you will have a reduction in caffeine clearance and an increase in the half-life. And there's also like biological data for that, and it's mainly because the oral contraceptives are inhibitors of the CYP1A2, and there are some drug-drug interactions between oral contraceptives and caffeine metabolism. But smoking results in induction of the main enzyme of the CYP1A2. And so this is what you can then basically study and build computational models to better understand, okay, where is this coming from? How strong has this to be induced to have such a change in caffeine clearance and so on? Yeah, but this is just as an important side note. Like basically everything you put in your body has like can often affect many of the enzymes, and it's often crazy what here what the combinations are. Like that's like if you eat a lot of broccoli or a lot of smoked meat, or I don't know, that's all resulting in a change in your enzyme amounts. Often you see an induction of enzymes if you take things which are metabolized by these enzymes. And this changes, of course, also how you metabolize drugs which you should take. Like, I think this is a good example. Like, there are certain psychopharmaca and fluxoamine and so on. I'm not sure if this is the right name, but it's basically they're going via the same enzymes. And so, like, if you change your smoking behavior or start taking oral contraceptives, you will suddenly have like very different plasma concentrations of these drugs. And often this, yeah, let's say, like, it's never too good to make too big lifestyle changes, but there can be a lot of drug interactions we're not even aware of. A good example is grapefruit juice, which has like a lot of interactions with many drugs, and it's more like, okay, it's one of these poster childs of food drug interactions. So personally, I would say, like, if you take medications, you should probably not drink grapefruit juice to be safe. But especially for elderly, this is like very problematic. Okay. Yeah, so I think this was a main overview. Okay, what is pharmacokinetics, and where is this variability coming from, and how we're working with the data? And now we really have to go towards understanding the pharmacokinetics of lisinopril, ramipril, and start getting the data for the computational models. Personally, like I said, I worked on many of these other substances, but I have no clue what lisinopril and ramipril are doing. So we basically start today a bit working on that, and then we have to basically everybody has to read a paper or two and start like extracting and understanding the pharmacokinetic data in the paper. And I think this is also a really good exercise because then you really it's much more tangible if you really worked with the data and extracted the data and read a pharmacokinetic paper. So normally, what is the first step in such a project? It's we're doing a systematic review of the literature and trying to find publications which worked on with the pharmacokinetics of the substances we're interested in. So I would say the big task for the model is really to establish now a pharmacokinetic database for these two substances, so that we can build the computational models. Because we can start with the models already, but we need this database basically for the parameter fitting and the model evaluation and so on. So this will definitely be one of the big tasks we have. And within this task, like, a first thing is, okay, doing a literature research and finding literature which is relevant for the for this data set. Yeah, so a big part, like normally how you start is we have collaborative literature management system. We use Zotero, and we normally perform two kind of searches. The one is really a PubMed search, and the second one is database, which allows to search for this pharmacokinetic data. And then we establish a first, it's often called in this research, it's a corpus of publications. A corpus is just a fancy word for a collection or a set of publications which could be relevant. And then, of course, we have to evaluate in which of these publications really appears pharmacokinetic data, and what does it mean for our model. Okay, so let's jump right in. I already performed this search for the ramipril, but I will just do the same now for the lisinopril. And until now, we basically don't have any data for that. So the first, basically, we do two searches. The one PubMed is a big, it's basically the biggest database for scientific literature. And then there's also like some specific databases which contain literature for pharmacokinetic data. And there's specific literature. It's basically called TKDB AI. And there we can perform a search and look for publications which could be relevant for us. So we would go to the paper search and search for a drug here. And okay, ramipril I did already. Lisinopril. exists here. So we would basically just search for that and see what this database is giving us. We're seeing we're having here 76 results, and these are somehow ranked by their importance. We see here somehow that's called as PK relevance and so on. And already from the title, we would say, okay, this looks like a probably pretty good publication, which will likely contain pharmacokinetics data for lisinopril. So here, a study of the potential pharmacokinetic interaction of lisinopril and digoxin in normal volunteers. And also here, there's pharmacokinetics of lisinopril. Like already here, we're getting this looks pretty good. We see also this is now also the I'll say like this. It's brainstorming. So basically what you see here is already like you have to think about the possible applications of such a model. Like for instance, here in the top hits, we see already something like lisinopril pharmacokinetics in chronic renal failure. Okay, I mentioned in the first lecture, like this could be some interesting question. How is renal problems affecting the medication with ACE inhibitors and so on? And so there seem to be some data for that. There's also like a lot of drug-drug interaction. Here also renal function. Also like, okay, we the point is also like we want, of course, also understand, okay, often this is done in normal volunteers, this small clinical trials. Of course, we want to also understand if the pharmacokinetics in hypertensive people is perhaps different. So this could also be that often many of the studies are done in healthy volunteers, and then if you go to the hypertensive people, you have a different pharmacokinetics. So this could also be some question. It's more like comparison of it's often comparison with other drugs or drug-drug interaction here, co-administration, pediatric patients, so certain subgroups and so on. And you can already see here from the titles there's a large variability, and you have to find the interesting and the good papers for that. Okay, so good. We would download the results here for this right now. And in this case, I just save it under downloads. I normally with such searches, if you do like some meta-analysis or something, you should always document what you did and when you did it, because many of these databases just change the content over time. So we did this today on the 17th of November, and then we can save that. And we would now I would just open that here to get a quick overview and show you what is in here. So this is basically it's a comma separated file. Okay, import that somehow in an Excel sheet, and what we get here as an output is basically an index. We get our, now we have to check. We basically got our 76 results, 75 results. Something. Oh no, 76. It starts at 0, and we get the and we get also the PubMed IDs here. So this is basically the publication which is describing the things, and we want the publication and see what is in there. We get the titles, and we got also a score, and the score is basically this match, how good it is. And so basically everything which is up here seems like pretty good, but if we go down here, we have more like this doesn't mention so much pharmacokinetics or reviews and so on. So this is probably not so good, but it could still be good, and we have to evaluate somehow. Okay, so this is basically what we have here. I would have now, I need the entries for Zotero to import. This is more like we have to do a bit of a trick. So I basically getting the PubMed IDs, and then I use PubMed to get the real the metadata for the PubMed IDs. So just opening this site, PubMed, a large search site for scientific literature. And if you have the IDs, you can basically just search for the IDs. And then you see here we got the same 76 results. and can now save them in a format which we can import into Zotero or other literature management system. So what we want is basically all results. And for the import, we need basically the PubMed format. So I create this file, download it. Okay, and I have to somehow move. See, no, here, also store what I did here on today, the 17th. And this is our PubMed data. Save, and then we can use that to import it into Zotero. So until now, we don't have any pharmacokinetics. So I would now import something. File import. The import window popped up down here. I want to import from a file and use the file I just downloaded. Oh man, should have clean this modified other direction. November. So this here, the PubMed entries, and then we get place imported collections into a new collection, copy files. This is all good. And then we're importing it and get here a new collection here. Okay, 76 items were imported. This looks good. And I will just move this in the lisinopril pharmacokinetics so that we have it at the right point and just rename that that we are a bit consistent. So this is basically our PK PD AI search we performed today to get this information. Okay, so this was basically the first half. So we see now we have 76 publications here, and we already have the. Oh, this takes probably a bit of time. Sorry. Oh, not sure. No, here. Yeah, we basically have all the metadata and so on. So this is already pretty good. We have abstracts and so on, and this is all already in our database. And now we would perform an additional search directly via PubMed to see if we get other interesting publications. So what we want to search here is really for the lisinopril and pharmacokinetics, and then see how many results we get. Okay, then we get a bit more results, 241. But we would do the same import now, save all results on this page, save it as PubMed, create file, and we save it as I will just call it PubMed direct. Okay, and we would do the same import in the here in this folder. So I need okay, file, import. Okay, this opens here. A file. Next. Modified. And we have here our direct search. Here, open, place, space. Sounds all good. Okay, and now we should. This was not enough. Something went wrong. I think I saved it not correctly. So okay, so this was definitely not what we wanted. Delete collection. Oh, wait, what do I have to do? I have to delete everything? Oh, good. I just want to.
Yeah, best is to delete with collection with items.
Okay. Okay, so exactly, delete collection with items. Perfect, this one. Okay, so I'm pretty sure I forgot to select all results here when I did the save. That's why I got the wrong things. All results, format PubMed. Okay, and now I should get more than 10 results. Replace, and let's try the import again. And that's why it's always important to have the numbers somehow to just check if this is if sanity is happening, if sane things are happening while you do things. I would say this also in the whole working with pharmacokinetic data and so on. You always have to double check what is going on and think a bit about the data, and then you will find a lot of things. And yeah, it's really critical. This is an important thing when you're really doing research, like to being critical about what's happening while you do it, because most of the time it's it's not happening what you think it's happening. Okay, so we're waiting for importing. This looks better. This already takes much longer. And we have 241 here. This looks good. 241s were imported, finished. And so we would also move this here and do the renaming. And I would call this just PubMed from today. The lisinopril we don't need, right? Because we are already in the lisinopril folder. So, okay, so far so good. Now we have searched this, and we have in total 317 interesting papers which could have like pharmacokinetic data. What we see already is some duplicates here. This looks very similar, like this Vandenberg 1988, 1988. So that are definitely duplicates because both methods found like papers which are identical. So the first step is now to find the duplicate items and remove them here. And most of this is pretty straightforward. So I will just click here on this merge, probably like a few times. Yeah, this looks all good. Vandenberg, Dugan. So I probably have to click now 70 times, but this is okay because often most of the things which are in this pharmacokinetic database, they're also directly found via this PubMed search. But often there are like some special papers which are not in with this other search method. Like with these two methods, we have now an initial corpus, and often this is extended during the project by following additional references. So it's more like you saw an interesting paper which contains pharmacokinetic data, which is interesting for modeling, and then it references in a discussion or introduction other papers which did similar work, but they often didn't state that in the title or in the abstract, so it's pretty difficult to find them, and you have to go this indirect way via other citations. Okay, just merging all that. Not sure how much is left. Yeah, it's probably we got with the other 76 items, so most of this is like duplicates, so I'll probably have to click just around 70 times here, and we can already see this are really the identical papers. If you look here, it's always the identical title, and also the first author is the same, and so the two methods really gave similar results. Okay, let's see how much. Yeah, unfortunately, I have to look a bit critical if there's something really strange, but normally this looks all good. But we see we're already through. Thompson. We see also like metabolites, lisinopril. Okay. There was some renin. This is also like this related to the blood pressure. But there's also data like here, like I'm not sure if this is really relevant for us, but this renal impairment looked really interesting. So, okay. So this is basically what we have. The next step would now be getting the actual publications for that. I'm not doing that because this takes a bit of time. So it would more like find available PDFs, and this would retrieve the PDFs which are freely available. And then we have additional methods to get more PDFs. And normally we can, I think, cover 60 to 80% of the PDFs which are available. We did this already for the Ramipril. And if you look here, yeah, you can basically see the small PDF icon next to the entry. Yeah. So basically, just imagine I would now get the PDFs here, and then this lisinopril would look very similar to the ramipril folder where I basically performed 2 hours ago with Yannick together this same search. Yeah. Okay, and now the next step is basically to evaluate where do we have like good pharmacokinetic publications, and which are really like interesting things which we can look at. And so normally what is happening then, it's one has to go through this entries. These are 180 items, and just see what are good studies. In this case, I would just take a bit of a shortcut and just look where I have pharmacokinetics, but this will ramipril. Oh, and I have to write it correctly. Oh, man. Yeah, probably everywhere. Yeah, pharmaco. Okay, 200. And just look for an interesting study. The problem is we need things where we have PDFs, and we need something where pharmacokinetic data is in there. So let's see. Like, okay, there we don't. Here, this, for instance, is sounds interesting. It's basically bioequivalence, as often if you give 2 different doses. And here, ramipril in healthy volunteers. This looks pretty good. So now we would basically look at such a publication and see, could there be data in there for ramipril, and can we learn something from that for our models? Of course, here we already have to say, like, we have to figure out what is basically happening. I will just annotate a bit that you see what's going on. We have healthy volunteers, we have ramipril. Main thing is normally that you well, for me, like, I scroll just through the publication and look at the figures and the tables. And what we see here, this looks not too bad. And it looks very similar to what I showed before. Like I said, like, if I would have to guess, like, the curve should look like that after oral application. And this is also pretty clear that this was oral application. But you see, yeah, the first thing we can learn here, okay, there are 2 metabolites, ramipril, this is the drug we give, and there's also a second substance measured, which is called ramiprilat. So this seems to be most likely a product. Next thing we can learn definitely is, okay, we have very large error bars. This is more realistically what you see here, and you have to also see, okay, these are standard errors, okay, and so like the standard deviations I showed before, like, really they are, you never see something like that. Real variability is much larger, and yeah. But it also depends, of course, on how many subjects did we have and so on. Yeah, we don't know that yet, but okay, you can see that. Next thing we can definitely see is, okay, this is pretty fast absorbed. After an hour, we reach the maximum. And also the half-life is pretty short. And this is normally a good sign if half-life is pretty short, because it's easy to measure, or it's normally easier to measure. It's not so good for the if it's a medication, of course, if after 2 hours it's everything away, and this is the substance you want to is reducing your blood pressure, then you have to take the tablet every 2 hours and in the night or whenever, and nobody is actually doing that. So my next, basically, I'm sorry, I have no clue what's going on, but these are just educated guesses, like working with such data. So I would, what we see, like, if you compare it to that, to this product, or probably metabolite of ramipril, this has a much longer half-life. The curve looks similar, it goes up and down, but this is not via absorption, but probably via metabolism, most likely in the liver, that this is going up, but the half-life is much longer. This is like half-lives of, okay, here the half-life is 1 hour, so like not 2 hours, but yeah, okay. But here also, if you look from the peak, okay, when is this approximately half? Okay, I don't know. This is probably 5 hours, 6 hours. This looks already much better. And you could imagine, I would, if I have to guess, would say this is probably the active metabolite, which is responsible for the ACE inhibition. Like I said, I have no clue if this is true, but this would make much more sense, because this is more in a range where you would take the tablet 1 or 2 times per day. So this is basically what we can learn from here. Also the error bars are a bit smaller here, which is also somewhat nice. Some of the error bars are cut here. So this looks, I would say this looks like a really nice study. It's also healthy subjects. And so like an important thing would now to figure out, okay, what was done to whom? And then this is often here in the clinical protocol. There's a lot of information, blah, blah. But things like this here are really the important information. A total of 31 healthy male and female volunteers aged between 18 and 55 were treated in the present study and provided their written, okay, this is it. Were treated, this is what is interesting. Yeah, of these 31 volunteers, 13 were males, 18 were females. Okay, so that's pretty mixed. And then we also have like information about, okay, how much did they weigh and so on. Okay, so this is so we know already this is a pretty big group. 31 is we looked at 5 before in our pretender loan example. Here we have a lot of subjects, 31, but still we have very large variability. If this is the error, like basically this is standard error on 31 subjects, then I will expect, like my first guess would be this has an extreme variability between subjects. Just looking at this error bars and seeing for 31 people we have such error bars, this is looks dangerous. Next thing we see here, also very nice, we have here table where we see the pharmacokinetic parameters. And you can see this looks already pretty, it's like, if it's a good pharmacokinetic study, 90% of this is okay. You see time courses, mainly of a mean and some error measurement, and then you see some pharmacokinetic parameter. And then here we see, okay, we have Tmax, and yeah, here we have, like I said, like around 1 hour. Okay, it's a bit shorter, the half-lives. And for the ramiprillad, you're much higher, and like basically, okay, half-life of 25. I wouldn't have guessed from the this data. But this is probably also due to the variability. It makes a big difference if you calculate the half-life on the mean curves, or if you calculate the half-life for every curve and then take the mean. But 25 hours I wouldn't have said from this curve, never. But here it appears this is around 25, and here 16. Also this I wouldn't have guessed from the curves, because they look very similar. For me it's strange that these two curves should have so different half-lives of almost 10 hours. So there's like, I would say, like there's lots of nice things happening, but also lots of red flags are coming up. But this is normally how it is. But that's what I mean with you have to be a bit critical and understand a bit what this means. Like also you have here Cmax in the table, and so you should check is okay, this nanogram per milliliters around 30 for both. Does it make sense? Okay, looks approximately right. But here we see similar things that if you calculate the parameters on the individual curves and then do the mean, it's often different than if you have the mean curve and calculate the parameter on that. But this is what we can do here visually. We see the mean curve and we can think about how the parameter is. But this should be in the same ballpark. Okay, but this is typically what is done. Here there's also like some comparison between the two things, but overall this is a very nice publication, and one publication we definitely should use for the model building. Especially these are healthy subjects, it's a lot of subjects. Reading it more, we have to figure out what's going on. Also how long they were treated. Yeah, they had two-way crossover study, what design, what washout phase, and so on and so on. So there's lots of details to that, but the overall thing is like you have to say, like by me picking randomly a study, this looks very similar to what I presented in the presentation before. Yeah. What we normally, so last point I want to make, what we normally do is now tagging the studies. So if we evaluate things, we normally add text to that. I have to see if I have to add some text to that. So I would definitely add a tag. Oh, I have to look up what we have to add. Sorry, I will need another 5 minutes and I'm finished. I'm just showing the tag thing, and then we're basically done. So yeah, normally I would add some tags. Like, did we already include this in the database? Also, do we get certain kind of data? Like, I think the most important tags are basically data, time course, data pharmacokinetics, and which species were there, and probably this check tag. Let's put this to the other side. That I have my that I have my checks, and so I would now add certain tags to that. For instance, I would here add the tag species human. We saw this was a human study. So often also this pharmacokinetic thing is not really done in men, but in dogs or pigs and so on. And of course, this is not data we can use. So the species tag is an important tag. And then we can give here for the species human, we can give certain colors. Do I have to do anything here, or do I have a color already now? Yannick?
Right click, also unclick it and then right click and then you can select color.
Oh, okay, assign color. Okay, so I have species human, set color. Okay, perfect. So this would be something here. I will just add the other two tags. We'll definitely add like something data data time course, because we have this in there, and we would add data pharmacokinetics as tags. And we would add like some name for checked. So in this case, I looked at the study, so I would annotate that. And sometimes we also give a priority tag. So this is a pretty good study from the first look at it. So this would get a priority high. And then we would just give a bit more colors for that. Data assign color. Set color. Set color. And the other tags we gave were, I think the species I already did. Yeah, species I already did, but the check tag I would also give for now a color. Probably this is later on we only have a certain amount of colors, so yeah. So the checked tags will probably not get colors, but the priority. So and then we by adding this tags, it's very easy to find subsets of studies and make priorities based on what should be used for the modeling and what has to be curated. I have to deselect this here, or how do I here? Or?
Yeah, yes, and deselect the two as well.
What and what? How? Which now is okay. And so yeah, but we see okay. We basically we evaluated our first paper here. So how many more to go? Ramipril, if I select this all, we see there are basically 209 items. So this would basically be like one of the first tasks, like basically go over the studies and see what is useful. And in the end, I expect there will be probably 20, 30 papers which are useful and contain data. And based on that, we can then, everybody would do probably 2 papers and read them and try to extract the pharmacokinetic data from them. And then as a group together, we have, of course, then can create a large data set by everybody just doing 1 or 2 papers. Exactly. But this is basically what we're working. Normally, this is doing 1 student for 1 project. Yeah, but here we can basically split that a bit. Yeah, we already saw like this. This looks pretty interesting, and we can learn like now I would say the main thing is now to learn specifically about the pharmacokinetics of lisinopril and ramipril based on this database of publications we now established. And so this would be the first step for the model, and then start data curation and model building with the actual data. Okay, so far so good. If you want to discuss, I'm still 10 minutes here. Otherwise, I understand if you have to run to other meetings. Yeah, if you have feedback, questions, please let me know. Otherwise, we would make, I would send an email like a bit with the instructions and what to do next and what to read and what to fill out. And so you should be able to do this without meeting. And we would also do the next week then online and talk a bit more about the pharmacokinetics here, of specifically about the substances. But then we have to meet and really do the data curation in a practical session so that everybody sees, okay, how do we create data? How is this working? And then can everybody go back and be online and work on their 2 papers. And I think this is what we probably will do before Christmas and have a nice database and also start a bit on the modeling part. Okay, floor is open for questions. So please, if you have anything, let me know.